Good evening or good afternoon. Um, I'm so delighted to be here with you. They gave me the task to talk about the acute heart failure. I mean, the session is later today, but because of my flight, so we shuffled the lectures. But it's good because I am in the middle of the arrhythmia and the EP session, because at the end of my talk we will touch base on that, and probably it will enlighten you. So critical decision making. So modern management of acute heart failure, early therapy, implementation and post-discharge prevention. This is my disclosure, I have none. So the modern management of acute heart failure compromises from four things. Early therapy when they present to the emergency room. Second is how to start your guideline-directed medical therapy, and when and how you're going to titrate it, because this is a big issue, by the way, and there is no consensus, by the way, still. I mean, even if you go through the guidelines, they say titrate, but still. But we have some sort of an insight how we're going to do this. And then you have the pre-discharge assessment before you send him home. I know for sure we are sending patients home early, by the way. And then the post-discharge prevention, and this is where the limitation that we face. I know some the hospitals, they don't have a heart failure service. Some they do. Most of you, general cardiology, may be very restrained to have the patient come every week. So you're going to touch base on that. So this is the burden for heart failure. I will highlight that the burden is very high. It's more than the colon cancer, breast cancer, and prostate cancer. This is how you're going to manage this patient, early therapy and decongestion, because once they present to the emergency room, you have to stabilize the patient with the hemodynamics. Next, you have to relieve the symptoms by giving diuretics. Next, once you give the loop diuretics, you should think about vasodilator and inotropic support. And we face this a lot in the emergency room. I'm not going to touch base on this because I know most of you are doing this in your hospital. Next, the use of high flow oxygen or the use of non-invasive ventilation. Next, time to therapy. When and how we're going to initiate the guideline-directed medical therapy. And then we're going to go to point zero, the point where you're going to stabilize this patient, because we know for sure blood pressure will drop, heart rate might drop, kidney function might deteriorate. Then you have, this is like, a cascade of so it's just like some sort of integrated, you have to take the patient through this journey. So how are you going to, clinical evaluation, I'm giving this to the students, but now I'm giving it to consultants here sitting with me. SPLASH, symptoms, past medical history, life signs, assessment of congestion, rule out STEMI and equivalent like non-STEMI, and also hypoperfusion. So you have to do this in your assessment when somebody presents with acute heart failure and you have no diagnosis for the patient yet, either HFpEF, HFrEF, related to MI, not related to MI. This is the cutoff for the natriuretic peptide. I'm not sure about your hospital. Our hospital and the governmental hospital, they made it universal. The cutoff is basically 100. Two, rule out cutoff is less than 100. Now, we know rule in is 400. Remember, by age, for the pro-BNB, differ by age. But for the BNB, it is more than 400. Now, the gray zone, you have to interpret it according to the clinical situation, between 100 and 400. So you remember these cutoff and check your reference range in your hospital, how you're going to interpret this according to your hospital. Troponin T, yes, is going to be elevated. Troponemia is very common in acute heart failure. It's very difficult sometimes, especially if it was stable troponemia, most likely it is heart failure. If there is a peak, you have a problem. You have to dig and make sure with other tools you have, echo, blah, 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 all these things, to make sure that there is not an underlying ischemic heart disease, because high troponemia associated with worse outcome. This is the flow. You assess the patient, make sure about BNB, make sure about the troponin, and then you're going to start the treatment for this patient. Giving oxygen, Lasix loop diuretics for decongestion, and consider vasodilatory therapy if systolic blood pressure is more than 110, okay? Either you can use nitroglycerin or either you use nitroprusside. The second thing is how you're gonna give the Lasix, because always we are asked if there is somebody here from the emergency room, if a Lasix naive patient, give 40 and reassess again with the urine output and urine spot sodium. If it is previously have been taking Lasix, give 80 milligram and reassess again the situation. Later on, you have to do all the tests. Not all hospital in the Gulf, they have echo available in the emergency room. Unless if they have POCUS to check for dilated cardiomyopathy or like wall motion abnormality. If you are lucky, then it's good. Not all hospitals, they have cardiology on call. I know this for sure. So echo is a tool that you can do it additional test later on if you don't have it really available for the emergency room. This is the guideline, the 4 pillars. You have the diuretic, SGLT2, MRA, and also the ARNI. The problem is, even with this, still there will be some sort of a residual risk. And therefore, in the coming few months, you're going to hear about adjustment for a 5th pillar that's going to come into play, which is the soluble guanylate cyclase. Next is using beta blocker and also using the iron therapy for these patients. We know for sure that long-term decongestion and intensive implementation of heart failure therapies, that the cold and the wet, I don't know if you see it there, it's not clear, they do worse. So therefore, if you discharge the patient early without decongesting them, you know for sure they're going to have a worse cardiovascular outcome and death, which is, we call it vulnerable phase. So the 3 key elements for underpin and optimal transition: the patient should be fully decongested. Next, you start the guideline-directed therapy plus titrating it up and optimizing it. And next, you should have some sort of a structured, if you don't have it, refer these patients to heart failure subspecialty. This is the decongestion workflow. You need to reach euvolemia. You need to switch from IV to PO. If it was an IV infusion, you have to calculate and have the dose. For the IV, you have to convert at least 1/2 of its oral equivalent. Before discharge, reassess the patient. If you have the luxury, do BMB. Make sure that you switch him to oral first before discharge, and make sure that he doesn't decompensate in the hospital. Keep him 2 extra days in the hospital. It will not harm you. To make sure that he's euvolemic on oral medication. And then the post-discharge, make sure that probably you're gonna give me 3 minutes more, okay? Subsequent reduction with for the Lasix. And how are we gonna up-titrate initiation? This is how you're gonna do it. You need to have the worsening symptoms, you need to have blood pressure measurement, and you need to do some labs. So we know for sure there is lack of awareness from the physicians, and that's why you are here to get more aware. Patient, we have a lot of things: patient frailty, old age, medical cost, medical limitation that you might have in your hospital. We learn from strong heart failure that optimizing guideline-directed therapy with increasing the doses, they do better. That's what we learn from strong heart failure study. And the result, with up-titration inside the hospital, cardiovascular death was reduced by 26%. So how are you going to do this? Because, after all, the patient had an acute event, you need to diagnose him, you establish everything, start, because you want to make him ready for the discharge and then follow up. This is how you're going to ideal sequencing guideline-directed therapy. 1, if the patient is naive for guideline-directed therapy, you have to start 2 things at least: SGLT2 and the MRA. If the patient has evidence of previously was in HFrEF and is well known, continue on beta blocker. Don't stop the beta blocker, basically, okay? I know some of internal medicine colleagues, they might stop the beta blocker. For the de novo heart failure HFrEF, beta blocker should be started after stabilization, after decongestion, then you can start the beta blocker. ARNI, There you go. We learned from previous studies that ARNI is very, especially from pioneer heart failure, the cutoff for starting the ARNI is systolic blood pressure more from 100 to 120, 50 milligram. If it was more than 20, you can go ahead with 100 milligram. Trick. If the patient on ACE, switch him to ARB and then start ARNI. If you don't want to do that, have a 36-hour for the switch, okay? For like ACE inhibitor, you can stop it and then you can. So this is what we do right now in the hospital. If the patient ACE inhibitor, we switch him to ARB, and then from ARB, we switch him to ARNI after 1 day or 2. Other consideration for African descent, hydralazine isosorbide, all of you know it. And the newer one, which is using the ivabraline and vericiguat, especially for worsening heart failure patient. Please, this is the red flags. If the patient is getting readmitted again, if the patient is progressively not responding to diuretics, consider referring for LVAD and transplant. And old age, always be tackling them nicely. Outpatient visit, this is it. This is the highlight of this lecture. For systolic blood pressure, excessively low and symptomatic, ARNI and RASI and MRA should be maintained at the same dose and not up-titrated. Next visit, you might up-titrate. Potassium more than 5.5. Check what is the reason for the high potassium. You can consider potassium binders. Heart rate less than 55. You should, the beta blocker titration should be done cautiously. Ivabraline also with cautious. Probably you might not start in such situation. In GFR, 2 things. Less than 25, less than 20. 25, خلي بس هذه, and then that's it. Because that's what we do nowadays in the clinic. If it was less than 25, reconsider the ARNI. If it was less than 20, reconsider the SGLT2. Pro-BNP always should be done for the clinic. It should be done for the clinic. So you know, if there is an increase of 10%, increase the diuretic therapy. Iron and TSAT, the greatest benefit when the TSAT less than 15. So you know for sure that they will benefit from iron therapy, nanoparticulate carboxymaltose. This is for the cardiac implantation electronic devices. If you have a patient admitted, always think about EP. Please have your EP colleagues to evaluate, because you know so many things have changed over the last year, okay? And the patient type, I'm not going to go through it. The EP colleagues, they will go through it with you, inshallah. You want to take a picture of it, take a picture, because it's very important to risk stratify the patients and referring them for EP for the benefit of the CRT therapy and also pacemaker therapy. My last thing is regarding the this is patient, you can delay their going for transplantation by having them in a good GDMT. So you may delay for at least 7 to 10 years with treatment, inshallah. Thank you.
Thank you very much, Khalid.